everybody smiling now up there. Well, it's an honor to be here this morning. And what I'm going to be reviewing is sort of a part of me now in terms of our practice. I've over the years, I'm not going to go in detail, Chris kind of touched on the highlights, but I'm sort of evolved into what's doing restorative medicine now with a background in functional nutrition in college, learning animal research, and then epidemiology, infectious diseases, immunology, wearing all those hats, and trying to solve what I was talking to Angela about, which when I came out into practice, physicians held back patients that had what we call MUS. MUS. Does everybody know what MUS is? That's medically unexplained symptoms. Now, you may have occasionally encountered some of that, MUS. So I'm going to share with you a journey of one of the patients that I've taken care of here recently during this pandemic. So it will illustrate some of the challenges that we have. I have no conflicts of interest this morning, and the slides I'm presenting are my own, or I've taken the liberty of libertying. So libertying are some of the slides I've edited from various experts. And this presentation is designed just for educational purposes, by the way. I always encourage you to work with your own healthcare professional on the information I'm presenting. And I'm going to discuss various research studies, and some of this will be off-label therapies, repurposed drugs. And right now there's no FDA-approved drug for long COVID, which we'll come back and emphasize. This slide provides an outline and objectives of what I'd like to accomplish this morning. Understand the basic concepts ascribed to long COVID. Now, I'll have to be honest with you, there's a lot of fuzzy areas with this. So I'll try to be honest with you and try to explain it simply so I understand it, so you can understand it. Describe the current understanding of what we call the immunopathogenesis of long COVID. And then I'm going to give you an update on how we're managing long COVID in the office in collaboration with others. And I'll touch on a slide of how you could prevent getting long COVID. And those that know me probably know where I'm headed with that, right, Brian? Well, let's start with our journey with Jane, and I've changed her name around. But I saw her in August of 2020, and some of you may have blocked out that year for various reasons. But she had been referred. She was 38 when she initially got sick. She was 39 when I finally saw her. But she had MUS, medically unexplained symptoms. She believed she had COVID infection. Her husband was sort of an important person in Omaha and travels around a fair amount and had brought home this illness, and he was in bed for a good week or so. And she had 3 kids that got sick, and she got sick. At the time, she didn't know for sure what she had, but in retrospect, it was probably COVID-19. She had upper respiratory symptoms, nasal congestion, and cough for about a week. Then afterwards, she developed PEM, if you know what PEM is. Post-exertional malaise, post-exertional malaise. I learned that soon when I came into practice because of chronic fatigue syndrome is one of the hallmarks of chronic fatigue syndrome is post-exertional malaise. These people, if they try to exert themselves, they're in bed for a couple days. She started developing cardiac palpitations, shortness of breath. She wasn't sleeping well at all. Anxiety with a lot of panic attacks. She was married, 3 young children. She had a fairly high level functioning job, but she became disabled and had to quit that job. So she was disabled by the time she saw me. And by the time I saw her, she had seen multiple physicians as well. So in summary then, when I saw her, she was 39 years old with MUS, including the fatigue, shortness of breath, proximal tachycardia, palpitations, insomnia, brain fog, and anxiety. And like Lucy, declaring to Linus, I'm sick and tired of being sick and tired. And as many of the physicians she'd already seen, they just kind of threw up their arms. What am I supposed to do? Send you to a psychiatrist? So this is our approach in general to MUS. We do a very comprehensive history and physical. It usually takes 2 to 3 hours, that initial visit, of being able to review all records and seeing the patient, and a thorough history exam. I have various questionnaires I have them fill out. I've learned, I mean, if they've got up to over 200 symptoms of long COVID, I want them just to document that for me, or I'm just going to get fatigued and tired myself. I look at what are called antecedents. We go back several generations and what may be genetic predisposing factors. We look at triggering events, and there's 5 major triggering events in life that you're probably aware of, and it starts with infections. It also includes allergies, toxins. Stress is a major factor sometimes in causing immune dysregulation. And then, I hate to say it, but SAD, or now we call it HAD, Standard American Diet, or the horrible American diet. We do a comprehensive lab evaluation. Initially, we educate counsel on optimal nutrition, realizing everything you put in your mouth is going to determine your underlying health and longevity. And then we emphasize, I got 12 S's we'll go through on modifiable lifestyle habits, starting with making sure your biologic clock is set appropriately and your circadian rhythms are in sync. And diagnostic tests was eventually performed in this patient, which we'll come back and talk about, that helped reinforce that Jane had long COVID. Well, let's look at some of the basic concepts of what we now understand about long COVID. We're going to go to the computer and actually do a little search like Snoopy. And I identify with Snoopy because Snoopy's my age. Peanuts came out the year I was born. So when you see Snoopy, you can think of me. So if we put in long COVID into PubMed, as we've shown here, obviously we're not going to get through all these articles this morning, but there are over 35,000 articles in PubMed as of September the 9th. Various terms that are used for long COVID include post-COVID, COVID long haulers. PASC is a common one, or the post-acute sequelae of SARS-CoV-2. And I almost refer to these patients sometimes as post-infectious disease sequelae patients, post-acute COVID-19 syndrome, late sequelae of COVID-19, and finally, chronic COVID syndrome. Well, how do we define what long COVID is? Well, it's a constellation of signs, symptoms, conditions that develop after acute COVID-19. It can be anywhere from very mild to totally incapacitating, like it was in Jane's case. Many definitions have evolved, and it usually starts about 4 weeks. Some would extend that out to 3 months of ongoing symptoms, and may occur just with mild infection to more severe infection. And this begins to get a little noisy with the symptoms outlined here, all the potential organ systems: cardiovascular, respiratory, kidney, musculoskeletal, general, mental health, nervous system, metabolic, endocrine, GI, skin disorders, coagulation. And many of these symptoms are very vague, and that's why I use questionnaires. I want the patient to really document, and I quantitate the degree of how these symptoms are affecting their quality of life. Some of the unique features shown here, of 10,000 participants, there were 37 unique symptoms of potentially more than 200. The 12 symptoms that were identified as most likely PASC: loss of smell, taste, post-exertional malaise. Again, that Penn, cough, brain fog, thirst, palpitations, chest pain, fatigue, loss of sexual desire, capacity, dizziness, GI abnormal movements, hearing loss, heat and cold sensitivity I would also add to that list. And these symptoms can certainly wax and wane depending on their activity level. And it turns out there's a lot of crossover between 3 other entities, and that includes ME/CFS, myalgic encephalomyelitis, chronic fatigue syndrome, fibromyalgia is in there, chronic EBV, potentially. And all these kind of share this profound fatigue and with or without PEM, and a so-called dysautonomia, which we'll come back and we can discuss in further detail, and so-called brain fog, the memory problems, and concentration, and so on, can be very profound, and then sleep disturbances. And this can have a profound impact then on quality of life. Leonard Calabrese directs rheumatology, chronic infectious disease entities at Cleveland Clinic. His daughter actually ended up going into the fellowship I would probably have gone into now, which includes infectious disease, immunology, and rheumatology. Those three have really come together as a triad of specialty, and she practices there at the Cleveland Clinic with him. But he quantitated on this slide the various symptoms in long COVID. You can see fatigue standing out there at 58%. Headache isn't that uncommon, 44%. And we'll come back and look at what we now understand about the immunopathogenesis behind those symptoms. And we can link certain things with those symptoms in terms of the laboratory tests we're doing. Well, what's the chance of developing long COVID? Well, initial studies suggest it was up to 80%, but accurate estimates are very difficult because of the underdiagnosis, limited post-COVID care, limited use of the building code, and many long COVID symptoms are relatively common, and as I've sort of alluded to, it crosses over into this ME/CFS, fibromyalgia, some of these other post-infectious syndromes, including EBV. Well, if we look at this data as presented by the National Center for Health Statistics and ask, well, have you ever experienced long COVID? If you have had COVID-19, 30.3%. Ever experienced long COVID who had COVID in Nebraska was about 30.5% too, tabulated. So a third of our Nebraskans who got COVID ended up with some duration of long COVID. Currently experiencing long COVID of all adults in the US, 6.8%. And if you look at the US population of over 250 million, that means there's over 17 million people, 17 million people living with long COVID. And it's estimated the cost of long COVID now is in the trillions of dollars. So this is a significant problem. And not to belittle avian flu or Marburg virus, but this is real. This is with us today. These are the patients I'm seeing. Currently experiencing long COVID with COVID, 11.5%. And this is maybe the most important slide. How many of these individuals who are experiencing long COVID have significant limitations in their activity level? And that approaches 22%, or about a little over 1/5 are potentially disabled. Well, who is most likely to develop long COVID? Various studies here cited. Of course, we learn early on that various comorbidities, insulin resistance. In fact, Ben Vickman, if you need to read his book if you haven't. Why do we get sick? And why do we get sick? What was his major theme in that book? It is centered around insulin resistance, which then leads to cellular dysfunction. You know, being overweight, unfortunately, that extra tissue triggers a pro-inflammatory response, triggers what we call your inflammasomes. So if you're overweight, you're always constantly on fire a little bit with inflammation. Anxiety, depression was a predisposing factor, probably relating to the neural inflammation going on. HIV too, because of the dysfunction of the immune system. Being female, possibly race, ethnicity, socioeconomic status, tobacco user on those slides, and recurrent COVID-19 infections increase your risk of long COVID. And this slide goes through various host and viral factors potentially associated with increased likelihood, including, again, reinforcing what we reviewed, the hosts, the lifestyle factors, and then finally a summary of key findings on the reinfection, vaccination. We knew up early on at least, vaccines seem to protect against long COVID. I can't tell you with certainty now that that's the case. And the affected population shown there. So right now, you're probably all very tired, fatigued, a long morning. So I'm going to teach you something. We're going to do a method here before we go on. I want to reset your sympathetic to a parasympathetic nervous system. Sometimes patients tell me, this is the most important thing I ever told them to do. And it has to do with breath, how dysfunctional many people's breathing really is. And if you're familiar with Andrew Weil, anybody? No? Well, you go to YouTube, Dr. Weil, write this down, 4-7-8 breathing. 4-7-8. Now there's other breathing methods that I also teach my patients, but this is so important. If you do this for a month, you're going to have less anxiety, your panic attacks are going to go away, and you're just going to feel more restored, if I can use that word. So I'm just going to do 2 cycles. If we do more than that, I'll put 20% of you to sleep, I'm afraid. All right, so this is, it's as simple as this. 4 is you inhale through your nose, and 7, you hold it for 7 seconds. So 4 seconds nose, 7 seconds holding, and then 8 seconds you exhale through your mouth forcefully with your tongue up to your palate. Put it up there. There's a little ridge right behind your front teeth. You put your tongue there. All right, so we'll go on the count of 3, okay? 1, 2, 3. Once more. All right, stop. You should feel more relaxed. And Andrew says if you do 4 cycles twice a day for a month, you're going to feel calmer after that period of time. And if you go to his YouTube presentations, he'll help you better learn what you're doing to your physiology. I'm a little tired myself. You should get a calmness, a calm energy, as we say. Well, let's go on. This is really the detailed part. And I really wanted you to be prepared, mind and body, to understand where we've headed with understanding the immunopathogenesis of long COVID. Well, there was this one study that looked at the phenotype of 152 persons with long COVID, as shown on this slide. And they could document significant immunologic differences, and this includes between acute COVID-19 and long COVID. There are distinct immunological differences. There's higher antibodies against SARS-CoV-2, and what we see is actually COVID-19 turns out to be another form of AIDS. It's not HIV, but it does suppress the immune system. And it suppresses it in a number of ways, probably. And one of the important ways, it suppresses your so-called CD8 cytotoxic T cells. We used to call them suppressor cells back in the 80s and 90s, but they're really cytotoxic cells. When those go down, you lose some of the surveillance for these chronic herpes viruses, which most of us have, a few at least, including EBV, CMV, human herpes virus type 6, herpes simplex virus, and last but not least, varicella zoster virus, the cause of shingles. And there's differences which we'll focus on in terms of what we call cytokines. There's a super cytokine family, and you come across this day in and day out probably, but it starts with cytokines, chemokines, and chemokines are the attractants. It's the honey that attracts the bear. There's interleukins, interferons, tumor necrosis factor, transforming growth factor, and so on. And those are all within this super cytokine family. Those are the text messages that is going on in our body constantly. And through machine learning and AI, we found that there can be a distinct immunological pattern, or signature, if you will, with long COVID. Well, this slide summarizes a lot, and we're not going to go through all these 5 entities, but it starts with immune dysregulation or dysfunction of our immune system. one of my passions, of course, as you well know, is the microbiome that we have. And I could spend all day on this, by the way, but I have 2 YouTube presentations online. You could go and learn about how we view the microbiome, called Weed, Seed, and Feed Your Microbiome. Weed, Seed, and Feed Your Microbiome. I did this with Robert Luby, who directs education for the Institute of Functional Medicine. Autoimmunity and immune priming is one underlying cause of long COVID. We know there's ongoing vascular disease, which we'll come back and look at in greater detail, and then dysfunctional neurologic activity. Well, we know that every vaccination, including COVID-19, can be associated with various adverse reactions. I think Andy, who gave me my 3 COVID vaccines, we sort of, talked about, to be prepared, and it all seemed to go pretty well, a little soreness in my arm. Yet, and what I'm gonna maybe go over in a fairly brief period of time, and we can come back and talk about this further, there is a long vax syndrome out there, and there's no hiding anymore from that reality. In fact, I had a nurse that, and I won't go into detail, but it was at another medical center. She's a big researcher, and her first Pfizer vaccine, within seconds, she got anaphylaxis. She ended up with myocarditis. Because of her connection, she ended up at the Mayo Clinic, and they, yeah, this is all myocarditis. And then they sent her to me and said, you treat her. And I said, well, how do I treat her? Well, we can come back and talk about how you treat myocarditis. But fortunately, we got her myocarditis resolved. So there is a long vax, which she ended up with. Well, I hope you know this, but again, let's just go through what your patients are reading. I think it's important that we don't hide, and I'll come back and have a slide, the so-called ostrich approach. Let's don't take the ostrich approach, but let's look at what is out there, the science, if you will. Science is a method. There's not a single person in science, it's a method. It's a way of looking at reality, of what's really going on. This came out just recently, and it took a Polish economist in a public health department, I think, to put the literature together and a perspective. And again, this isn't my opinion, this is what was published. And I'll just read you the conclusion. The early scientific literature was biased. In fact, we were all told the vaccine is very safe and effective, but serious adverse events began to get reported, were actually repressed, but only in the last year have scientists been able to publish articles that acknowledge a high number of these serious adverse events, maybe approaching 1 in 800. Earlier on, I can't tell you that with any certainty now, but this should be a warning that science should be completely objective when evaluating health risks, but can often be influenced by social and economic considerations. And you can go and read the paper that's online. Are we biased? Do we have economic pressures? Well, this came out actually in 2021. Dr. Theodoridis and hypothesized some of the damage in fact with SARS-CoV-2, especially in the brain, may be due to a certain corona spike protein on the surface of the virus, or what we're making with an mRNA vaccine. Could this be toxic? Well, if you recall, the spike protein interacts with ACE2 receptors, and these ACE2 receptors are throughout the body, present in a variety of human cells, we know. And we now know that the vaccine does, what stays in Las Vegas stays in Las Vegas. We were led to believe what was within our deltoid state. It doesn't. It goes throughout the body, we now know. Potentially every organ in the body can be infected. In fact, locally, and we'll give you the book that just came out, there's a bioengineer that has showed that whenever you inject in the deltoid, you get some of that uptake in the blood vessels locally, about 1 centimeter. So you're always getting, and that destroys those little endothelial cells. And the nurse I cited, she had to get it injected in her bloodstream as sick as she got and as quickly as she got. So, the old concept, we talked about this the other day, Brian Walls knows, and that you should aspirate when you inject a vaccine, and I kind of pointed that out early, but I'm not sure where to, I don't think we're aspirating, which I feel pretty strongly about. And so we go back. One of the main areas of dysfunction is the so-called renin-angiotensin system. Casey Means just wrote a book, Good Energy, by the way, and if you really want to know what's going on at the cellular level, she's an ENT physician that dropped out after 1 month, or 1 month before she finished her training, and has a company called Lumens. And she goes through how, these chronic diseases, we start with reactive oxygen species, that leads to mitochondrial dysfunction, that leads to chronic inflammation. And if we can't control the reactive oxygen species, we get inflammation. And what is happening via the spike protein, we're blocking formation of our normal antioxidant system. And Theodoros went on to hypothesize that the spike protein may affect a number of immune cells, the virus itself, as well as the spike protein gets into the brain. Well, let's take a closer look at the spike protein so you understand what we've been looking at clinically. A closer look up here. So if you look at the spike protein, it consists of S1, S2. S1 has 2 receptor binding domains, and as the virus docks to your ACE2 receptor, which the S1 is responsible for, the S2 allows it to penetrate through the membrane, and the S1 is released into wherever, the tissue, the bloodstream. It's like bats in the belfry. Or if you've experienced, like I went down in the kitchen one day, this bat was lying around. Who are you going to call? Well, the Humane Society there, of course, they came and got rid of the bat. But who are you going to call to get rid of the S1 circulating blood and tissue? And we'll come back and review that question. Well, all these are nice theories, of course. What's the evidence? Well, this publication in 2023 kind of reviewed in detail the evidence behind this concept that the spike protein may be toxic. And I won't go through all this, but the various elements, factors that are documented, including these lipid nanoparticles, widespread distribution of mRNA, DNA, and another factor you may hear more about is DNA contamination that possibly incorporates itself into our genome, downregulates genes that protect us from cancer, and upregulates about 17 genes that can lead to cancer. So is there such a thing as turbocharged cancers? Well, that's been proposed by some. Again, these are somewhat theories, hypotheses, or they're being thrown out, but that's what your patients are reading. And is that why we only have 3% uptake of the present COVID vaccine? I can't tell you that for sure, but I think these are issues that we need to be addressing. And this publication went on to show you spike protein in cardiac tissue, in autopsy series, and in brain tissue. This is an interesting blog that came out. This is by a Canadian ED physician, and I just give you the reference. It's Mark Trozzi. He's been somewhat controversial, but he is presenting a very interesting review of, as he notes here, a new wave of disease, 44 common examples of injection-induced illnesses supported by over 930 scientific articles. And I would challenge you to go back and read all those. And they're peer-reviewed. And I'll just show you 2 slides from what he reviewed. But if you look at this, reported adverse events compared to normal vaccines, and I'm not an anti-vaxxer. I recently got my Tdap updated, which I was, it was a good thing because we're seeing outbreaks of pertussis. And I got my initial COVID vaccines, but look at that slide. Look at what is reported for COVID vaccine compared to all other vaccines. And you might, pardon my French, But WTF? I mean, look at that spike. That is pretty striking. If I was a patient and was given informed consent, would I take the vaccine? And I encourage my patients to review the information out there, and I try to give them informed consent. I don't discourage COVID-19 if they're a candidate for it in terms of the vaccine, but again, these all are factors that raise concerns for me. And this is a slide just showing you the 44 examples of vaccine-related problems, and that includes the myocarditis that nurse I encountered. And I've seen a number of these various conditions. And this is maybe one of the most alarming conditions being reported as a new pathology. And I hesitated presenting this because it's just before lunch, I know. But I think this has to be addressed. And it took morticians to identify the beginning in 2021, they were starting to pull out new clots, never seen before. These white, rubbery, amyloid-like clots, and up to very long in nature. And in fact, there's a mortician who's in the military that's been doing surveys, and he has found about the morticians reporting about 20% of the bodies that they're embalming will have these white clots in them. And I recently had a funeral director as a patient, and I'd never heard about how do you embalm a body, and she went through it in detail. And I asked, well, you're seeing these white clots, and she's in Iowa. She said, oh yeah, since 2021, we've been seeing quite a few of these clots in elderly individuals from nursing homes. So correlation, or is there causation being seen there? I think this is an area that really needs to be looked at. I mean, if we ignore it, it's kind of like, again, the ostrich approach. So what can we conclude about spikopathy? And again, this is a kind of a hypothesis, but it seems to be pathogenic, whether from the virus or created by a genetic code in the mRNA or adeno. And we should do away with the ostrich approach, as we say. Well, the pathogenesis of long COVID, which we have been looking at with Bruce Patterson, who has a company called InCellDX. Bruce was a pathologist, virologist at Stanford for 25 some years. In fact, he had some major papers and insight into HIV in the late 1990s in terms of the underlying immune pathogenesis that was going on. And about 15 years ago, he went out and formed a company called InCellDX that was looking at not only HIV, but cancer at the time. And he was actually over in China in the latter part of December of 2019 in Shanghai. And they were bringing in these reports at the time saying, there is some major outbreak of some infectious disease. They said, well, that's kind of interesting. Well, he went back to the US, and then beginning in 2020 through 2021, his company began to take a serious look at long COVID. And it kind of goes back, this research ended up being based on something that was published 20 years ago. And this set up the concept, many people still think atherosclerosis is caused by high cholesterol. Well, go back 20 years ago and read the research that shows that it's an inflammatory disease. It's an inflammatory disease. And if you were an alien looking down at atherosclerosis, or looking at a fire, let's say, you'd say fire trucks cause fires, right? And so it's cholesterol sort of in a way innocent bystander, but there's certainly familial hypercholesterolemia that needs to be managed. But it's the inflammation, and in fact, being infection preventionists realized that this may well be triggered by the endotoxin from gram-negative bacteria that come from your gut that has increased or a leaky gut, if you will, and that lipopolysaccharide gets into your bloodstream and triggers what we call these monocytes to become and evolve from classical or a non-classical monocyte, and they interact with the lining of the blood vessel via what's called a fractalkine, the receptor, attaching. And from there, they can cause a local inflammation. They recruit platelets that cause microclotting. In a sense, you're trying to heal a damaged area of the blood vessel. And these monocytes, which are the largest white blood cells in your bloodstream, twice the size of a red blood cell, They roam around, they come out of the bone marrow, last a day or so if they're classical, and they go into the tissue and evolve or morph into a macrophage, which can carry on various functions. Dendritic cells, if you've seen little dendritic cells with the little dendrites, they sit down in your gut and they have these little dendrites that go right through your cell and checking what's going on in the lumen. Oh, just ate a ham sandwich. Was there mail or not? Well, anyway, they draw back their little dendrites and then wander off into the lymph node where they interact with so-called naive T cells. But those monocytes play a very pivotal role in vascular inflammation. And this was a publication, it was 2020 that these two cardiologists hypothesized that it looks like COVID-19 is a microvascular disease, acute COVID-19. And what I'm going to show you is that long COVID, at least in some of our patients, may be a microvascular disease as well. And they went on and showed this picture how the virus itself can cause injury to the endothelium, or the spike protein or the mRNA that's injected will cause local or widespread vascular damage if injected into the bloodstream. And it sets off a cascade of events. And in fact, you can see this VWF, von Willebrand factor, is released in an inflamed endothelium. And that's one of the blood tests I'll do always on our patients to see where they're at with a vascular inflammation, or what we call endotheliitis now. That is an important marker we look at. This publication in the New England Journal will kind of reinforce the concept of endotheliitis, clotting, so-called angiogenesis, which is VEGF, which I'll come back and review as a marker of angiogenesis. And so what we really have is this ongoing imbalance at the level of vascular endothelium. Well, let's just briefly go through Immune 101. As you know, there's an innate part of the immune system, and at the center of that is the monocyte, which again can morph into macrophages, dendritic cells in the tissue, and then you have the adaptive immune system. We do quite a bit in terms of working with our patients, and this starts with the questionnaires we use, that within the bone marrow you can release a naive T cell, goes to the thymus gland and get a little college training, so to speak, then wanders off to the lymph node, and there it is waiting for these antigen-presenting cells, primarily dendritic cells, or the dendritic cells are the professional antigen-presenting cells. Now, macrophages can do both phagocytize and present antigens at the lymph node level. And what they do is, depending on what they picked up, what antigen they picked up, will communicate with the naive T cell to polarize. And there's 7 main subgroups of polarization at that level. This doesn't include the Treg cells, but for example, you can polarize towards a Th2. All cancers in general are associated with a Th2 dominance. Just think about that a little bit. All cancer, what does that mean? We should be addressing that. Allergies are associated with Th2 dominance. If you've got mast cell activation, which we'll just briefly touch on, and we can come back and talk further, that's a Th2 dominance. And then you see a Th17 dominance is where you get ongoing chronic inflammation, and for whatever reason your T cells polarize towards Th17. All autoimmune diseases in general are associated with dominance of T helper 17. And all these are sort of communicating differently in terms of their cytokines and chemokines and so on. Well, it was in 1989 that it was identified, not only do we have these classic monocytes, but we have intermediate and non-classical, and identified by CD, which is cluster of differentiation. Cluster, you've seen the CD, CD4 were the cells that HIV attacked, and we saw depletion of CD4, and that led to AIDS once your CD4 count was less than 200. With COVID-19, interesting, it's not so much CD4 that's being wiped out, but again, CD8. CD8, your cytotoxic T cells, and we see our patients with long COVID consistently having levels less than 600. And there's various markers that are different here, as you can see, between the CD14 and 16. And these slides get a little noisy, but there's distinctive functional differences between classical, intermediate, and non-classical, and differences in cytokine production. That especially as you get into non-classical, you get tumor necrosis factor alpha, interleukin 1B, and IL-6. Those are three major cytokines that are inflammatory, And this slide kind of reinforces that with intermediate and non-classical, you get a change on receptors that appear on, you begin to get what's called a CCR5, which stands for cysteine chemokine 5. And that was a very important receptor we identified in HIV because we have a drug that blocks that receptor. That receptor is on HIV, but we also find that on the non-classical monocytes. And that interacts with a so-called ligand. Remember, ligands are like the honey that draws the bear, that there's a CCL5 on the endothelium, the blood vessel. And when you get a cell, which are usually in low numbers, but what we're seeing with long COVID, a significant increase in these non-classical monocytes, they're drawn to the endothelium and interact with the CCR5 on the monocyte, with the CCL5 on the blood vessel. And not only that, but remember back in 2004, we identified those, and it turned out non-classical monocytes had fractalkine. So we have two docking sites for these monocytes that lead to inflammation or thrombal inflammation, with clotting to follow because of the platelet. And this shows like an EM, the monocyte here with the CCR5 interacting with the endothelial CCL5. Well, so Bruce Patterson and his colleagues in about, this was published about 2021 as I recall, actually 2022, the research was in 21. What they looked at was over 158 different cytokines going on in acute COVID and long COVID patients. And they, through machine learning and AI, they were able to come up with a long hauler index and reduce it down to 14 different cytokines that would predict long COVID, and we'll go over the sensitivity and specificity. But then they also began to look at the concept that, again, back in 2004, that there were these monocytes that were leading to vascular inflammation, and that the signals they were picking up that there was microcirculation inflammation going on. And indeed, the monocytes, as they cross into the tissue, polarize these T cells to what's called Th1, and that's a high producer of two major inflammatory substances, starting with IL-2 and tumor necrosis factor alpha, and that led to their development of this so-called long hauler index. And I'm going to skip through that. So the pathogenesis of long COVID, data from their laboratory in CellDX has shown that again, more maybe of a hypothesis, but long COVID is vascular inflammation caused by persistence of S1 protein in monocytes. What's going on here? Well, they developed a test by we can document, as we'll see in Jane, I could document that she had circulating monocytes with S1. Remember, that was a little bat that got into the belfry flying around at my house. So it appears what you call, when you have S1 free and circulating, you call your, not the Humane Society, but your monocytes, right? You call, and indeed it's the lower level non-classical intermediate monocytes that appear to then absorb this S1 fragment, if you will. And they went on and did this study, and actually this was patients with vaccine-related or long vax, and could identify a different signature of cytokines. Primarily IL-8 was the one that was up in our long vax patients. And similar symptoms, though, as long COVID. Well, so how do we diagnose long COVID? Well, I have to be honest, there's no universally accepted blood work, although the test I'm going to show you, InCellKine, is approved in Europe now as the test for long COVID. They have an approval process. It's approved in Europe. You can get this blood test in the UK, in I believe it's Spain now, and actually it's approved down in Brazil. So if you want to travel down to Brazil, you can get it there as well. But So as with Jane, we start with a comprehensive history and physical exam, and then we offer them this 14-plex cytokine panel called InCellKine that helps at least support the diagnosis. And the test is a test for, again, long haulers, long COVID. There's a distinctive immunologic pattern. There was a preliminary study that showed a sensitivity of 97%, specificity of 100%. This is a more recent summary of the sensitivity, specificity, positive predictive value, negative predictive value, which is kind of important because if we can do the test and reassure the patient you don't have long COVID, that can be a very reassuring thing, not perturb their normal non-infected controls. And then you can see here with severe acute disease, but as we get into PASC or long VASC, you know, the sensitivities are greater than 90% with a very good specificity of 98%. Now, I won't get into this, but we've got involved in doing research now for ME/CFS as well as, some of the worst reviews I get online is when I say, oh, there's not such a thing as chronic Lyme, but now I come around and I actually seen patients and studied patients with chronic Lyme. And it has an immune signature that's really interesting. And what it is, it's similar to maybe what we see with COVID-19, but what Bruce Patterson has shown is that there's a fragment of the cell wall of Borrelia burgdorferi that appears to be taken out by these monocytes and can persist in a similar immune dysregulation. And he just recently published an exhaustive review of the research they've done in that area. It was actually their last reference I put on the slides. So again, I think there's still some fuzziness here, by the way, but it's something that we've been involved with. They have now enrolled 43,000 patients and have treated 18,000 patients with what we're going to be reviewing, and they have a double-blinded randomized study that's going on right now to look at, is this real or not? And I think that's important. Also, we have an immune subset panel that they can do quantitating classical, intermediate, non-classical monocytes, and is that individual still carrying spike protein? Well, let's review then Jane's treatment and management. Again, when we finally saw her, she was 39, presented with these symptoms when she was 38. I always start out with these 12 S's. A baker's dozen, if you will. We won't go to the 13th S. But have them eliminate or subtract things initially. Subtract. And of course, as you well know me, I say subtract out, of course, the ultra-processed foods, refined sugars. But I come around in an area where I'm really looking at more closely. I think blue light may be the most toxic substance we deal with. If you're overweight, it's probably blue light toxicity, by the way. And there's some research, very interesting, and we could go back over that, but I think blue light you need to address, and your biologic clock and circadian rhythms. And then we can just go through all the various S's, and grounding's very important. I sleep with my lovely wife, has grounding sheets and grounding pillowcases and all that, if you're familiar with that concept, but that's another talk. And last but not least, I think you've got to understand as you're sitting there, you've got a soul and you're connecting with me, and that soul is for eternity. And so be sure you got the keys to heaven, because that is so important, because you don't want to spend time in the other side of things. Well, this is a little cartoon slide. If you're afraid to go into the ocean because of sharks, you might want to avoid hotel hallways, I should say hospital hallways and break rooms, because vending machines are twice as likely to kill you. Statistically, I think the chance of a shark is 1 in 100 million. Chance of getting killed by a vending machine is 1 in 200 million or so. Or it's vice versa, the other way around. But more importantly, what I emphasize is that junk food you're eating there. And I say ultra-processed foods in my page, say, you mean junk food, right? Yeah, I say, if you eat that, recent studies have shown not only will you decrease your health for life, but decrease your life as well in terms of longevity. So again, I tell them, you gotta cut out these there's emulsifiers, additives, and so on. Well, let's look at Jane now. Now this slide is really noisy, I'll have to admit. I'm just going to briefly go over it, but this is a good example of the patients we're seeing that initially comprehensive history and physical. She has chronic EBV active reactivation, which is still very fuzzy. There's Hank Belfour up in University of Minnesota that's been doing ongoing research that I interact with. But this is an area that is somewhat fuzzy, but there's 4 markers we look at for EBV. In 2020, she had markers for all 4 of those. Fast forward to September of this year, she still has all 4 markers. You know, I am not quite sure what that means, but there's things we try to do to enhance her immune system that maybe control EBV. There's an entity called mast cell activation syndrome. I've given you the reference for consensus 2. This is about 17% of the population seems to be prone to mast cell activation. If you're familiar, mast cells are your bouncers, so to speak. Go to the bar, the bouncer to keep the bad guys out. Well, these keep the bad things out of your system. They're wherever you interact with the environment. If you got allergies, by the way, that's your mast cells. Mast cells release over 1,200 mediators. And the one you hear most about is histamine, of course. That's why you take antihistamines, leukotrienes, that's why you take Singulair. But we're seeing patients that just have a very explosive mast cell type of problem. And that is going on in the brain as well. And this was an entity, it took me some time, but after an ID doctor in Finland published a nice review, there is a concept of mold hypersensitivity. Mold hypersensitivity. That the mycotoxins released by various molds, and up to 50% of buildings are mold infested now, that it triggers immune dysregulation. In fact, the #1 trigger to mast cells probably are mold toxins, according to Jill Carnahan out of Colorado. So that, and their house was mold infested and they had to mediate, so we had to get that under control. We looked at how her T cells were polarized through a so-called lymphocyte map. She had autoimmune, she had a positive ANA, positive TPO. She had autoimmune processes, but not disease yet. And that related to that, again, Th17. And then she had various micronutrient deficiencies. And then finally, she'd get up and she'd get dizzy, not true POTS, but a component of dysautonomia. So she had all these ongoing symptoms, probably had COVID in March of 2020, but definitely didn't have it in 2020-22. And then probably again in August of 2022. And it was at that point, as we were getting everything else resolved, we began to consult her further about this in-cell-kind test that was available. And she had, as you can see, it's a 14 cytokine panel. She had one of the highest long hauler indexes I've seen. Usually we'll see like 2 or 3, but hers was 19.56. 19.56. And if we carefully look at the various 14 cytokines, again, IL-6, IL-8, TNF-alpha, interferon gamma are pro-inflammatory cytokines that are being picked up. And then she had evidence of endotheliitis. Again, a hypothesis that these cytokines, soluble CD40L is found on the blood vessels. And when the blood vessels are inflamed or injured, they release CD or soluble CD40 ligand, again, that honey that draws things to the blood vessel, into the bloodstream, and we can measure that. And VEGF is a reflection of angiogenesis, or new blood vessel formation. So she had a very high long index. So the treatment, again, we go through the initial comprehensive evaluation in various lab that I'm not going to go through in detail, but it turns out that based on what Bruce and his colleagues have seen, and now treated over 18,000 people, that Microvascular is an HIV drug that we use because it disrupts that CCR5, CC5 ligand, the ligand receptor interaction. It disrupts that on the blood vessel, these monocytes, along with statins that disrupt the fractalkine interaction. And so by disrupting that fractalkine and that CCR5, CCL5 axis, these monocytes then can go on, because apoptosis, which is where cells naturally die, that has been down-regulated in these cells for some reason, but by getting these cells detached from the blood vessel, they can undergo apoptosis and go away. So she was still having some symptoms as we went along. We did the immune subset, and indeed she still had circulating spike protein as of August, having started her treatment in July. So we continued treatment a little longer and did a follow-up in-cell-kind test in November, and here she's down to 0.45. Almost 20 down to 0.5. And by this time, she was feeling much better, by the way. So we had not only laboratory evidence of improvement in dysregulation, but we also had clinical evidence that she was getting better. So I'm just going to go through quickly. There's a lot of research out there on repurposed drugs. Again, there's no current FDA-approved therapy for long COVID, but we're finding that this combination of maraviroc and a statin in the setting where we have documentation of an elevated long hauler index is of value. You know, one of the repurposed drugs, I learned about this in the mid-'80s when I came back to Omaha. I was asked to review maybe the first HIV patient that died at one of the hospitals, a young guy with MSM and died of AIDS and pneumocystis. But you know, through the 80s, we initially had AZT. We'd have our patients get up, take 2 tablets every 4 hours, set the alarm and everything. We learned within a few months it became resistant. So we were repurposing drugs back then. And the one drug that was looked at in the mid-1980s was low-dose naltrexone. If you're familiar with naltrexone, it's kind of an orphan drug. It's used for getting people off opioids. But it hasn't really been used for other things. But we learned back then it had some interesting value. And now there's some studies, one VA study in people that had long COVID. This is a smaller study, but they showed after 4 weeks of taking low-dose naltrexone, we're talking about working at the 4.5 milligrams, 4.5 at bedtime, that after, and they compared this with amitriptyline and one of the antidepressants, and then with physical therapy. And the star of those 4 was actually low-dose naltrexone after 4 weeks. And 2/3 of patients had decreasing fatigue, increasing cognitive ability, were sleeping better, and decreased pain. And in part, the cognitive benefit here is that, again, remember we talked about toll-like receptor 4, which interacts with spike protein or the virus. Low-dose naltrexone will penetrate the blood-brain barrier and then blocks that receptor, TL4. Then that blocks the inflammation, blocks the microglia activation in the brain. So that's something we look at with patients as well. There's some side effects to that, though. So this is my one slide. How can you protect yourself against long COVID? Well, this goes back to practice healthy lifestyle habits. And they've shown statistically here, if you have a normal BMI, never smoke, 150 minutes of physical activity per week, ideally out in nature, getting under trees, sunshine, and high quality nutrition, along with moderate or less alcohol. And I think, as we all know now, alcohol is toxic at any level. And then adequate sleep. Those are protective factors against long COVID. Well, just briefly then, these are patients when we see them. Sometimes they come from Madonna. Sometimes I'll refer them to Madonna, but be aware Madonna in Lincoln, in Omaha, and I assume here in Lincoln, I have not checked this out, but they have an excellent multidisciplinary program about for physical therapy and neurocognitive ability and counseling and everything. And some of my younger patients have really found this helpful. Now there's a site that may be somewhat controversial, but these are the frontline COVID critical care physicians. But if you go, they have some treatment regimens with various supplements. And I always kind of go to consumerlab.com, which is really an ongoing, they really do their research and comparing supplements, are they real or not, in that category. And then be aware, this is a research site, volunteer, it's called React-19. They're doing a research study with the University of Maryland right now. And they have some excellent resources to better understand what's going on with the COVID vaccine. Now these are books that I'm recently recommending. I have all my patients get Stanley Rosenberg's book to learn about how you stimulate your vagus nerve. That is so important. And then James Nestor's book, actually a general surgeon brought this one to my attention, although I was aware of it. but it's entitled Breath. Both of those books have good exercises in the second section. I mentioned Casey Means came out with her book on good energy, so you understand reactive oxygen species, mitochondrial dysfunction, chronic inflammation, and what needs to be done. And then there's an Omaha. He graduated from Westside in 1968. I interacted with him some years ago. And at the time I asked him, well, Steve Gundry, what do you think about the microbiome? He says that's interesting. I may look into that. Now he's written, his 6th book is on the microbiome, about gut check. And he really takes a deep dive, especially autoimmune patients. I sent him some of my tougher autoimmune patients. He's out in Palm Springs now. And there's 2 podcasts. The one, Mast Cell Matters, that seems to be picking up more and more traction with patients we see. And then Raylan Eagle's kind of interesting. She had chronic fatigue herself, and every week she's interviewing people. What did it take to resolve your symptoms? What did it really take? And both of those podcasts reinforce the imbalances we're seeing: immune dysregulation, impaired vagus nerve, and your limbic system. We be aware of how important the limbic system. I see people come in because of limbic system hyperactivation with heart attacks. They have perfectly clear coronary arteries, but it's your limbic system. That's the system that makes you very sensitive, your emotions. So you've got to be able to control your limbic system. Well, again, to YouTube, if you're Roger Sewell, I followed through the COVID-19 pandemic. He's got 4 board certifications. He's an intensivist, pulmonologist, sleep therapist, internist. And he has some excellent reviews of how important sunlight is, by the way. And then another nurse, researcher, who may be somewhat controversial, but John Campbell, he's showing her the recent book, The Needle Secret, and what happens when you vaccinate somebody from a bioengineering standpoint. So in summary, long COVID is a clinical syndrome with signs, symptoms, or conditions developed after acute COVID-19. As we've emphasized, potentially greater than 200 symptoms. It's estimated that 11.5% of people who had COVID are now currently experiencing long COVID. We're into the millions. And again, importantly, 22% of those are disabled. And it's associated with multiple symptoms, 12 symptoms of note there. And it's what I refer to in the Cleveland Clinic with Leonard Calabrese, maybe is the one responsible for the concept of bundling together autoimmune, autoinflammatory conditions into IMIDs. And I refer to these as IMIDs, immune-mediated inflammatory diseases or disorders. And I think long COVID should be maybe a 3rd category now in those IMIDs, because it is an immune dysregulation associated with endotheliitis. And again, we've reviewed some of the suggestions that the spike protein may be toxic or pathogenic. And the InCell DX has developed these tests that we reviewed. And again, Maraviroc, statins may play a role in treating. We're waiting for the double-blinded randomized study information. And the initial management, again, it should be comprehensive. There's a lot going on with these patients. And to me, again, it always starts with modification, subtraction, addition to nutrition, and modifiable lifestyle habits. I've included, and I'll apologize, I haven't had time to collate all the references, but about 6 slides of references. And I've actually looked at these and at least scanned through them, but again, at your leisure. Definitely don't stay up at night and expose yourself to blue light. And so I'm going to conclude here. As some of you know, I stepped down from doing infection prevention control, being a medical director at Methodist for 43 years, August the 1st. After 43 years, I thought, well, maybe I'm going to move on. And over time, I've sort of subtracted out various things I've done. But I focus now on restorative medicine, trying to apply principles of infectious disease, infection prevention, epidemiology, immunology. So there is life after infection control and prevention, by the way. But it's kind of joy in ways, but I'm staying in touch. I'm in the background, acting maybe as a counselor, if you will. But again, what I emphasize, and we had gotten together the other day, I emphasize the one thing I want you to take away. Maybe I put a little stone in your shoe for some things. But I think the most important thing is you go on in infection prevention and control, be a critical thinker. Be a critical thinker. We've been through I think the worst 5 years I've experienced since I came away from Texas Children's Hospital in '81 back to Methodist and Children's. That, you know, all my training along the way pressured me to be a critical thinker. Look at the data. And there's 10 principles, and we're not going to go through them all, but I'll start with the ad hominem. Ad hominem. Brian, what's ad hominem?
You attack a human.
What?
You attack a human.
Well, yeah, you attack a personal attack, and it's not an argument with reason or substance. Follow the data. Look at the data, right? And so all those are potential flaws in reasoning, in logic. Be logical. Be a critical thinker. And I always like, again, Snoopy and I share the same birthday. Chocolate is the answer. Who cares what the question is? Chocolate is good for your microbiome, by the way. Well, thank you. I think, Andy, we have time for questions. I know you got lunch. I'll stay around for lunch,
Yeah,
but
I'll just say, I kind of like your concluding message here that, we have to be critical thinker. And also, I think, like the message about, as a healthcare provider, we should be sharing our kind of interpretation and giving the information to our patients. I was kind of thinking through what I have seen in this time, working with healthcare facilities throughout this pandemic, working with long-term care facilities, and one of the data set that I have seen is that Nebraska nursing home has done a great job, in vaccination and getting their residents vaccinated. We were actually at one point one of the top 10, top 15 states in vaccinating our residents, and actually we saw these top 10 states in least mortality among nursing home residents. And I think one of the reasons Nebraska has a better outcome is that our nursing homes have done well, and many of the infection prevention control program leaders here have worked, with those residents and their staff to keep them healthy and prevented. So I think one other recent kind of analysis, we looked at updated vaccine, and I'll tell you, based on the data for the nursing home residents, because we have very good data on their COVID-19 illness, because we have been testing every time there is a case in the nursing home. The up-to-date, at least in Nebraska, I'm not talking about general, because that's the data that we have looked at. At least in Nebraska, nursing home residents that are up to date actually have less hospitalizations. So I think their quality of life, because every time a nursing home resident goes to the hospital, that is a disaster, correct? So I think we have done a great job here. And when I talk to my patient, I definitely tell them that COVID-19 vaccine, when you take it, you will feel side effects. I actually just took it last week, and I specifically took it at Friday 5 p.m. because I knew what I'm going to get in the next 24 hours. So I was kind of preparing myself. But I think, to me, and that's what I tell my patient, if you want to if you're going through that one day of symptoms, but there's a greater chance, and we have seen that in our nursing homes where we have vaccinated and things like that, the outbreaks start to kind of dwindle down right away. So if you can prevent that infection from happening, that actually can help you in long term. Yes, one day you may have those side effects, but then after that, so I just got the 2024-2025 vaccine. Yes, I was, just sitting in my couch watching a movie on Saturday because I couldn't do anything else. But other than that, I came out pretty fine. So that's what I tell, the patient that I'm seeing in my clinics and things like that. So I agree that I think we should We should talk about the experience. We should talk about the local data too, and share that information also. So that's yeah.
Excellent. You know, you've done such a good job of educating and coordinating that. I think, have you kind of delegated that?
No, I'm still
All right, okay.
I'm still working
Still
on it.
there, all
Yeah,
right.
yeah. It's still there. It's
Is
still
the
looking
doctor,
at it. Yeah.
is a doctor who presents at the,
Doctor-
every 2 weeks?
Well, yeah. So I'm still overseeing the whole operation, but
Okay.
he's kind of taken over that.
That
work,
portion,
yeah.
okay, well, yeah, I mean, you should feel good about Nebraska, maybe not number one.
Well,
We're in the
we're
top 10.
definitely in the top 10 states in
Yeah.
keeping our residents safe in the nursing
Yeah,
home. Yeah.
sometimes you have to settle like Nebraska football, maybe it just.
Thank
Actually,
you.
it was a good game last week, I came down for that. Any other questions?
Thank you.
Yeah. I'll be around for that.